Welcome to another episode of the Federal Newswire Lunch Hour Podcast with your host, Andrew Langer.
Well, hey there, everybody. Welcome to another episode of the Lunch Hour with Federal Newswire. I am your host, Andrew Langer. And you know something? If you're watching us here on YouTube, you can listen to us wherever you find your fine podcast needs, have those fulfilled. If you're listening to us on one of those fine podcast platforms, you can also watch us on YouTube. Please subscribe, hit that subscribe button, leave us a like, leave us a review, and most importantly, tell your friends and family members and your family members' friends all about the Lunch Hour with Federal Newswire. Joined today, very excited to talk to this gentleman. His name is Jonathan Wolfson. He's the Chief Legal Officer and Policy Director at the Cicero Institute, which is a Texas-based think tank working on a wide variety of issues, a nonpartisan policy organization focused on fixing broken systems in the public sector. He has intimate knowledge of the government regulatory process and leads research at Cicero on healthcare and regulatory reform. Prior to joining the Cicero Institute, he led the policy office at the U.S. Department of Labor under the Trump administration. He also was an official at the U.S. Office of Agency for Housing and Urban Development. He is an attorney whose JD is from the University of Virginia. Jonathan, welcome to the show. Thank you so very much for joining us today.
Thanks for having me today, Andrew. I'm really excited to be here.
So let's start here because, you and I have talked. I've talked to you on the radio a little bit. These healthcare issues are very near and dear to my heart. Folks know my wife is a physician. And I will never forget, I was not someone who was involved in the healthcare realm before. I was strictly working on regulatory issues and property rights issues. And I'm driving up to see my folks in New York. This is literally like 2008, 2009 timeframe. And my wife is reading the Journal of the American Medical Association. And she says, Andrew, do you know that there is a growing gap between the number of physicians, especially basic primary diagnostic care physicians we have, and the number of physicians we need to serve the patient population that is growing? And that's only going to get worse. I'm thinking, well, that's really interesting because we are also focused on health insurance and confuse health insurance with healthcare. I was working for an organization at the time which was so focused on association health plans. How did we miss, how did everybody, Jonathan, miss the fact that this healthcare issue in America is really a resource economics issue?
Yeah, Andrew, this is one of those challenges that is big. It's getting bigger. And the solutions so far that people have proposed are kind of nibbling around the edges types of solutions, unfortunately. Your wife's story is absolutely right. It's a problem that we've recognized kind of in dribs and drabs over the years. But the American Association of Medical Colleges now predicts that the physician shortage is going to be somewhere between 100,000 and 200,000 doctors by the middle of the 2030s. And by the end of this decade alone, most states in the country are going to be short about 500 or more primary care docs. As you mentioned, those initial docs, the pediatricians for kids, OBs, family practice, those are the practices that you don't make necessarily as much money. And so people finish med school and they want to go become specialists. And, as a free market guy, I have no problem with people deciding what they want to do. But as a country, it is becoming a big challenge. And we've found ways to get people health insurance, to your point. But having health insurance doesn't mean you get health care.
Right.
You could go up at a doctor's office and say, hey, I have this card that they just sent me and they said I have health insurance. And the doctor says, well, congratulations. I'll see you in 6 months.
Right.
And for most people, that doesn't seem like they have health care.
It certainly doesn't seem like it to me. I mean, it's one of these things where, as I like to say, what we call health insurance in America is really like a Costco membership. And I am sort of using it in that way. But the problem is when Costco runs out of toilet paper or paper towels, they can just go and order more toilet paper and paper towels. In the healthcare world, we can't just do that, can we?
No, even the most, simple of a medical practice, and there's nothing simple about being a doctor,
right?
But in the United States, you have to go to 4 years of college, you have to go to 4 years of medical school, and then you have to do 3 years of residency. Yeah. And so we're talking about an 11 plus year process. And if you want to be a surgeon, residency is 7 years, right? So
Yeah.
just to get a doctor churned out of our education system, ignoring whether or not our system does a great job in all circumstances of training people, ignore every one of those things, ignore the challenges of debt and all those things. It's still going to be a 7 to 11 year process to get somebody just through the system to start touching patients and be able to provide them care. And that's really why at the Cicero Institute, one of the things that we've looked at in trying to get people access to care, and we've talked about a lot of different things, and we have policies on telehealth, we have policies on trying to find better ways to help people get the costs of care down. But in the access to doctors space, we feel like finding a way to get doctors who are trained, who are already touching patients somewhere else in the world, get them into the United States and able to practice immediately really does start to solve that problem right now, rather than putting this 10 to plus year window on it.
I want to come back to the solutions because I want to spend some time talking about that. I really want to spend more time at the up front, sort of framing the issue and how we got to this, if you don't mind.
Absolutely.
I just, because it's a situation in which I want to get at actually two things. Number one, and they're related, actually. It's two things and they're related. Because part of it is the question of how we got to this point, right? Which is why do we have the declining number of doctors? And it gets into number two, which is what I want to get your thoughts on. In an era, in any resource economics area, and I know folks don't like it when we talk about these things in strict economics terms, but as you and I both know, economics tells us about what's going to happen in a marketplace, right? It helps us predict things. So you and I both know that when you have increasing demand for a good while the supply is declining, right? The only way we know that in any system, price is going to rise, consumer price is going to go up. And the only way you can artificially keep prices down or work to keep prices down is by getting into this issue of reimbursement rates. So is this an issue of reimbursement rates? Is it artificially increasing demand? The mandates on health insurance have increased demand so that doctors are getting burned out. Doesn't that create a feedback loop? I know that's a lot there, Jonathan, but your thoughts on all of this?
Yeah, absolutely, Andrew. So I think that, demand is definitely rising for healthcare services in the United States. And there's a lot of reasons. You point out, providing more and more people access to health insurance does mean more people feel comfortable picking up the phone and calling a doctor's office and saying, hey, I want to visit. Right. And that's not necessarily a bad thing, right? I mean, we have to be really careful. More demand for healthcare is not necessarily a bad thing, right?
Agreed wholeheartedly.
The reality is there's more demand in the United States and in the Western world than a lot of countries around the world because people are healthier. And when people are healthier, they want to protect themselves from other sorts of things that are going to come in the long run.
And to admit that produces great long-term benefits, for society as a whole. If people are healthier as they get older, then that, we know the bulk of expenses are sort of the medical expenses towards the end of life. I'm sorry, Jonathan, go ahead.
No, absolutely. Well, but to your point, the fact that medical expenses are toward the end of life, they aren't really concentrated only in like that last year. They tend to be kind of as people age. Yes. And the reality is that the U.S. population, one of the drivers of demand is that our population has gotten older, right? The average age of the U.S. population has risen by a number of years over the last 30 or 40 years. We're no longer a country where the average age is in the 30s. We're a country where the average age is in the 40s. And you see this in even the doctor supply itself. So the supply of doctors, about 40% of doctors in the United States are going to hit retirement age by the end of 2020, by the end of the 2020s. And so what does that mean? That means that you're going to see more and more doctors who themselves want to step out of practice and move into their retirement years. Now, historically, people retired and didn't live that much longer, right? So when Social Security got created, the average, age of retirement and the average life expectancy were pretty close together. And so you could make that math work. And the reality is now you've got an aging population, and as the population ages, the demand for healthcare goes up among that population. And then there's other things that have also hurt or increased the demand for healthcare. We have more ability to do testing and realize that people have certain diseases. And so that drives up demand for healthcare. And there are wellness programs at work and things of that nature. And then on the supply side of the doctors themselves, we've got all sorts of challenges there. We have a challenge, as I already mentioned, of doctors aging out of the system. We have a challenge now, which is a difference of kind of American culture to what American culture and work used to look like in the 70s and 80s, where people want a work-life balance. If you talk to doctors who are nearing retirement age or even retired doctors and ask them how many hours a week they were working during their career, seeing patients in that work, we're talking 60, 70, 80-hour weeks.
Right.
And now that might have created all sorts of other complications for them and their families. And I'm not here to say that that's the better way of working. But if you're looking at this from a resource economics perspective of getting people access to care, every time you have people who decide to balance their work life in a different way that means more life and less work, what does that result? That results in fewer hours to see patients. And that means that more patients are going to need access to care. And one thing, yeah, go ahead, Aaron.
No, keep going. I'm sorry.
Yeah. Well, so I think one really big thing in that area is almost all of the data on physician shortages look mostly at the raw number of doctors. They don't look at the hours the doctor's actually working. And so if you have a doctor who has decided to work part-time because he and his wife have just had children and they've decided they're going to, work less, maybe you've got two doctors married to each other, and instead of them both working 50 hours a week, they're going to both work 30 hours a week so that one of them can get the kid to soccer practice and the other one can get them to piano lessons and all the other things that parents are doing to be good parents. But unfortunately, if you're the patient, you call and you say, hey, do you have time? They say, well, the doctor's only here 3 days a week. Well, that means that there are 2 days a week that patients aren't getting care. And that's not reflected in any of the data. Almost all of the utilization projections look at just raw numbers of doctors. And they say, oh, well, we have this many million doctors in the United States, and that translates to this many doctors per 1,000 people in the population. But that doesn't really work out if these doctors aren't working full time. You've also got on the supply side, a lot of doctors who are now working in different fields. You have doctors who are starting up companies, great for the economy, good, we want their innovation, but again, they're not seeing patients. Or you have doctors who are working for insurance companies. You've got a lot of insurance companies who've hired doctors to work directly for them, not to see patients, but to review bills and to do those things. Again, these are all perfectly reasonable things in the economy, but it reduces the supply of doctors who can actually.
As I said, having been married to a doctor now who graduated from medical school 28 years ago, I've seen all of this. We've, folks who've gotten out who are now doing, reviewing insurance things, it's certainly it's Matt and my wife, not on the doctor side, but nurses who've gotten all that training who now have gone into the aesthetics industry. And again, you don't blame them because you and I both know that the only part of medicine that really, or healthcare that works right now is anything that's for profit, right? Where they're actually working to innovate. And maybe we'll touch on that in a minute. Let me ask you this, because you touched on quality of life issues. And part of what we're seeing is the issue of, as you are being forced to do more in less time, right? We know that I use this when I talk about regulation. I certainly talk about when I talk about health, medical care. Line from, I know there was a poet who said it, but from Star Trek Generations, time is the fire in which we all burn. Time is the only finite resource that we all have. So there's a limited number of widgets of time in a given year. And so let's say that your patient panel was 4,000 patients, right? That means that you could dedicate a half hour if you were seeing patients 8 hours a day, whatever, of course, over the course of a year. All of a sudden, your patient panel demand jumps up to 6,000 patients a year. And that means you have X less time. It means, I was just talking to, I'll say this, my daughter is working in an ear, nose, and throat clinic this summer. She wants to go to medical school. And the amount of time the actual ENT doc, the specialist, has to see patients is piddling small. Let's say it's 10 minutes per patient per day. So, and I know it could be less time, but that's the thing. It's like there's a certain degree of burnout that happens there. Oh, and let's add to this, there is, of course, the huge pressure if you're part of a hospital system or a large insurance provider, right, to see as many patients as possible during that day. And that burns people out. You then get the issue of the greater incidence of mistakes that can be made. I just went through that, sorry, not to monopolize the time here, but I just went through this, I ruptured my Achilles tendon at a wedding. Went into the emergency room. They misdiagnosed it. My wife knew immediately what had happened. And then it was a cascade effect. And it took me another over a month to get it fully diagnosed. So, little things, little time, the amount of time you have, the pressure to go as quickly as possible, that produces errors down the road. Anyway, I'm sorry. Just, to get your thoughts on this.
Yeah, well, and I think that these are things that are burning doctors out. And, the number of friends I have who are doctors who have to chart at night, they see all these patients all during the day, and they may not be seeing patients for as many hours as some of the peers of theirs or their predecessors in medicine were seeing. But the number of hours that they're having to spend in an electronic health record, keeping good records, and to your point, they're worrying about liability risk, and the cost of liability insurance is a huge burden. And the amount of debt that they have, making it so that they don't get to actually really kind of come completely over that financial hump until many, many years into their practice. I'm an attorney by training and spent a long time practicing. And I was able to pay off my law school debt pretty quickly because you get paid a good bit of money right out of law school. But that's not what doctors are doing. They're going to residency for a small amount of money. And COVID just exacerbated all of those challenges for these doctors and burned people out, drove more and more people out of the practice of medicine.
Let's talk about that for a second, because and as we start to sort of move towards the solutions on this particular issue, because we got other issues we want to talk about today too, because we have a limited number of medical schools. Those medical schools charge a premium. I heard, and folks, and correct me if I'm wrong, Jonathan, but I believe you worked in the financial services policy side, the policy side of the financial services industry for years. I learned many years ago that apparently if you get a federally backed med school loan, you cannot refinance that loan upon graduation to get more favorable terms. If you go and you do move into a specialty and you're in the catbird seat, as it were. So you've got essentially a cartelized medical education, primary medical education, not graduate medical education. They can charge increasing amounts for tuition. You come out with massive amounts of debt that you can't then refinance, which further drives folks into specialties where they might be able to pay this off. Talk about that, and then let's start to talk about the solution side of it. Whether or not, let's talk about that. Let's talk about the debt issue, and let's talk about trying to break the stranglehold, and then we'll talk about the triage, the immediate solutions.
Yeah. Well, so I'm not positive on the refinance side, but I do know that everybody is kind of stuck in this strange world where the government is in charge of the student loan system. Yeah. And, as a result of the government being in charge of the student loan system, you do have schools that are willing to continue to raise the price of tuition because, and this is true in all of higher ed, at the point that you have to convince the student to pay with cash they're able to cobble together, you're only able to charge a certain amount. But if the point that the federal government is willing to pay the vast majority of that tuition cost, then, people are going to say, well, I'll pay this off over time. And everybody, because this is how people are, everybody is overly optimistic about how much money they're going to make and their ability to recoup that money. Now, medicine is probably a good investment. I'm not questioning whether it's a good investment to invest in those student loans. There's other programs we can absolutely have conversations about whether those make sense to do.
Underwater basket weaving, yes.
Exactly. That's probably prime among them. But there's others. The folks at the Foundation for Research and Economic Opportunity put out a report every year that kind of walk through program by program the return on investment from education. So there are good conversations on that. But I do think that the way the student loan system is set up has allowed the price of medical school to go up. Lots of people want to go to medical school, right? Your daughter, not one of them, but there are tons of people who apply to medical school and don't get in every year. Now, for some people who apply and don't get in, we as the future patients are probably appreciative that they don't get in. But there are also hundreds and thousands of people who are wanting to go to medical school who would be great doctors who don't get to go. And some of those people make a choice to go outside of the United States to go to medical school because they're not able to get into a school in the United States for whatever reason. There are some unique application and admissions things going on in the United States right now that may have driven certain people out. There's been some reporting on the training going on at UCLA. Again, these are questions about whether or not people want to even go to these schools. And so you see lots of people from the United States. We had some friends growing up I had a friend and her parents had come to the United States from Southern India. And she and one of her siblings didn't even attempt to go to United States colleges and medical schools. They literally, after high school, applied to and went straight to India, lived with family, and went to medical school in India, where medical school in India is a combined undergrad and medical school program in a 5-year program. So they were able to cut some years off their practice. They then they moved back to the United States, did residency, and they are practicing today just the same as any other doctor. These are U.S. citizens. These are not, the interesting thing is we've got about a third of our doctors in the United States right now who are a quarter to a third who didn't go to medical school in the United States. Yeah. Some of those folks are U.S. citizens. Some of them are not. Some of them weren't U.S. citizens when they went abroad, and now they've lived here long enough and they've become U.S. citizens. And so you do have a significant population of folks who are from overseas or who at least did their medical training overseas, who do come here, they do residency, and they then start practicing here in the United States. And so we started to think about, does it make sense to look at folks who similarly went to medical school outside the United States, but didn't do residency here? And was there a way to get those people to be able to get licensed here as well?
Well, yeah, and that's it's a perfect segue into that, because it is right. There are two ways, folks. There are two ways you look at public policy, right? You look at the things that are are going to be problems. Well, are problems now and are going to be worse in the long term. And you look at the long-term solutions where you think, what will help us down the road and the things you need to do immediately. And so this piece that you just said, Jonathan, up in the Wall Street Journal is about this triage, because you're right. And then I want to talk about long-term. You may disagree with me on this, and that would be fine. But let's talk about the triage. Let's talk about what it would take to bring in doctors from abroad and how many doctors we would be bringing in to meet this need.
Yeah. So, we've got this big demand or big kind of gap in demand and supply of docs, as we've already talked about. And so the piece I put in the Wall Street Journal highlighted some work that we at the Cicero Institute have had the privilege of working with a number of legislatures around the country and a number of governor's offices. And now there are 6 states in the United States that have passed legislation that creates a clear pathway that allows a doctor who is licensed outside the United States to come to the United States and practice medicine without repeating that residency. And so, we talked for a minute about the supply of medical school seats, but the more interesting kind of supply, little tight spot in the pipeline is residencies, where the number of residency slots that the federal government funds, they capped in the 1990s. There's been some growth. I'm not saying that the number is exactly the same, but the growth rate was capped in the 1990s because there was a fear that we were going to have too many doctors in the United States, which is kind of crazy. But in the 1990s, they capped the funding. And so as a result, we've seen residency slots really kind of lock in place. And so the population of the United States has moved. Oh, go ahead, Andrew.
Time out for a second, because this is something that my wife and I are constantly talking about with regards to this. And my wife says, well, we could increase the number of medical schools, but if we don't increase the number of residency slots, then it means nothing. Sorry, go ahead.
No, and I think that your wife has hit the nail on the head. And unfortunately, too many of the conversations, as I said at the very beginning, too many of the conversations about how to deal with this have focused entirely on medical school. And they've said, well, let's open another 24 medical schools and we'll train another 5,000 doctors. And now we've addressed our shortage. And I say, and many other people who have thought about this, I'm not, don't think I have any special insight on this. To your wife's point, unless you're going to increase the number of residency slots, then what you're going to have is a lot of people with an MD next to their name because they graduated med school. They don't get a residency, and now they're going to be in the worst of all possible spots. They're going to have all the debt from medical school. They're going to have a great amount of training, and they're going to have nowhere to work. And so now what have you done? You've just driven down the demand for the best and brightest to want to go to medical school because they're going to say, well, look, the likelihood of getting out of medical school and getting a job as a doctor has just gone way down because we've increased the number of people competing for this limited number of residency slots.
So I've been saying this for years, right? And then we're going to get back into bringing in the foreign docs and how many we need. And again, going back to 2008, 2009, that we should have started and should be starting now some kind of a NASA program on this. Now, listen, I'm not a big fan of using government resources to go down this road, but this is where we are, right? If we recognize that there's a national crisis, we have focused all of this time on insurance, and that has been, frankly, an utter failure, again, in terms of a resource economics problem. So, yeah, we need to go down this road and turn on the spigot of getting funding for these residency programs and then finding ways to encourage a variety of different universities, right? I mean, listen, you're absolutely correct. Not everybody who wants to be a doctor should be a doctor, right? But on the other hand, there are, I don't know how many, and maybe this is something that we could work on with the Cicero Institute, but I think it would be good to know how many qualified individuals are turned away from medical schools every year, right? Because maybe somebody has, and I don't know anybody, but just for the sake of argument, I have a friend who didn't do so well in inorganic chemistry. And it's not going to have any impact on their ability to practice medicine. But they got a couple of bum grades because they don't have the aptitude, or physics, right? You have someone who couldn't get their physics requirement done well, and so it knocked down their GPA by a couple of percentage or a couple of decimal points. These are folks who demonstrate full aptitude for being doctors. They should have that opportunity, and the federal government should, I think, be in the business of, if we recognize this is a national priority and this is a national crisis and we're already planning on spending money, let's spend money in the right way. What are your thoughts here?
No, I think that, if one of the things that we at the Cicero Institute believe is that if the government is going to do something, it should do something as well as it possibly can.
Here.
And so there are other organizations who believe that the best strategy is to try to take all resources from the government and just have them do nothing. And we believe that, pragmatically, that's just not going to happen.
Sure.
And so we think that, in part, we think that if you can figure out how to make a government program run well, then it justifies the expense of that government program. Now, is every government program needed? No, it's not. But if the people of the state or the country have decided they want to do something, then let's have that government agency do it as well as it possibly can. Use the principles of businesses. Let's use the principles of our founding and really use those principles to try to make things work as well as possible. And this is one of those areas where you can absolutely say, hey, what are the barriers to getting into medical school that are keeping qualified people out? And so if to your point, it's one exam that they didn't do as well on in college, then is there a way to address it? And one of the interesting things, especially in medical school, is the first 2 years of medical school are taken up with a lot of courses that most of those kids have already done in undergrad. And so I've talked to some people who think maybe we should even have a national conversation about kind of truncating the length of medical school in the United States for folks who already have science degrees, allow them to kind of skip or test out of those first 2 years of medical school and get right into clinical rotations where they're really learning to be a doctor.
That's absolutely right. And especially, what makes sense, especially in this era in which we are curtailing the experience of residency by putting all of these ridiculous these ridiculous limitations on the amount of work that residents can do. And I know a lot of folks look at this and say, well, it's just doctors saying I did it this way and you need to. But the reality is it's the clinical experience and the experience of working with patients and working with more experienced doctors to understand what's going on with those patients. That's the real education that's out there. I know, again, my daughter has learned a tremendous amount by working as a scribe. Not that she is qualified to be a doctor yet, but yeah, looking at what other countries are doing to educate, the folks who do the combined undergraduate and medical schools, and how does that impact things? But I think you're right, having this conversation about how can we accelerate to produce experienced clinicians without sort of sacrificing the requirements for patient for good patient care.
Right. Well, because at the end of the day, what we want to make sure is we don't want to change standards in a way that will allow doctors to treat patients and harm them. Right. We want to avoid that. But the reality is there's already malpractice that occurs with people who've gone through all the training. There's already doctor error. And so it's not like we have a foolproof system in the status quo.
And hold on for a second. And right now we are creating the conditions whereby those liabilities go up, those risks go up by having doctors see, more patients in less time. Sorry, go ahead.
No, absolutely. And so you've got to come up with that balance of providing enough training so that these doctors can do it. But to your point, providing them with the resources that enable them to be good practitioners, right? Having enough trained nursing staff, having enough good other folks a part of the healthcare team is really important for those doctors. And you want them to be enough doctors that a doctor doesn't feel obligated to start treating a patient when they know they're too tired, when they know that they are not able to treat that patient in the way the patient needs, because they say, well, if I don't do it, nobody's going to see this patient for another week. And that's just not helpful for the patient. But at the end of the day, if they make a big error, that's even worse for the patient. And
we need to be really clear about this because, there are ways we could, for instance, shift more of the diagnostic care to physician's assistants or to nurses. But, there are things that doctors understand and things within the doctor education that are different than in, say, a nursing education, certainly in a physician's assistance. By the way, this is why I was categorically opposed when the national, I don't know what their lobbying organization is called, but the lobbying entity that represents physician's assistants voted to demand that they rename physician's assistants associate physicians. I had a real problem with that because you and I both know, I don't have a JD, you have a JD. You know that when you become an associate in a law firm, it means that you're a lawyer. And there are partners and they're associates, and there are kind of different stratifications there. But you both have a JD. Someone who is an associate physician does not have an MD next to their name, and therefore should not be called an associate physician. To me, there's a certain truth in advertising there. But it gets to this. Let's go, because I do want to talk about some of the other things you're working on. So how do we do it? How do we, in the near term, how do we massively ramp up the number of doctors? How many foreign doctors do you think we can bring in logically to satisfy this gap?
Yeah. Well, so one of the interesting things, Andrew, is there's already a lot of doctors in the United States who are qualified, who would be able to apply under these programs. And so one of the things that's really important as part of this conversation is to talk about the folks who are here as refugees, the folks who have immigrated here, who might have a spouse who's working as a professor, where the opportunity to be a professor at the University of Texas is sufficiently lucrative that they decided to move up from Brazil and they just stopped practicing medicine in Brazil. And so there's a number of folks who are already in the United States who would be able to qualify if they weren't required to repeat residency as part of this process. There are also U.S. citizens who live in other parts of the world who might be interested in coming back. And some of them, would seize these opportunities as ways to come back. You have folks who are U.S. citizens who may have gone abroad because they married someone or their family had moved abroad. And so they decided to practice medicine in whatever country they've spent a good chunk of their life in. But now they have kids going to college or family members are here in the States who are ill and they'd like to come back and be able to kind of start establishing a life back in the United States. And this would allow them to do it. I also think that there are thousands of doctors all over the world who are interested in coming to the United States. The number of international licensed doctors who are applying to try to get residencies in the United States numbers in the thousands every single year. And so all of those people are folks who are already practicing somewhere else in the world, who are applying to try to get a residency so that they can get on a pathway to get licensed in the United States. I think those are the sorts of people who would be prime candidates. And then lastly, I think there's also thousands of docs around the world who would look at the income differential and the opportunity to make significantly more money. And this isn't just making more money coming from a developing country to the United States. Most of the European countries pay their doctors significantly less, even than some of our quote unquote lowest paid doctors here in the United States.
And hold on, and let's be really clear about this. They can pay those doctors significantly less because most of those medical schools don't charge tuition, right? Or tuition substantially less. So they come out with very little, if any, medical school debt, unlike in the United States. Sorry, go ahead.
Yeah, no, and there are reasons that those doctors are getting paid less, but for purposes of me talking to legislators in Tennessee or Florida when they pass legislation like this, or when I talk to the legislature in Idaho or Iowa, all of those folks are not as concerned about kind of the past for those docs. They're thinking, hey, how do we help treat the patient in our state right now?
The reason why I bring it up is because invariably when I've had these discussions with people about this issue, especially when we were arguing over the Affordable Care Act, back in 2008, 2009, folks would tell me, well, something, we don't have this problem. It's greedy doctors in the United States and they get paid this, in Great Britain or France or Italy or Germany, they don't pay their doctors this much. I'm like, okay, but by the same token, medical school, they don't have to pay medical school for over there. If you want to go and you join the public health service, you're willing to do that and go and enter their socialized system. You're not paying, you don't have a, $100,000 a year, bill, if, come out with $400,000 in debt. And they don't. So for me, it's about translating it to the other side when they make these specious arguments about it. I'm sorry. Go ahead, Jonathan.
No, and I think that that's a really important point. I think that so many things, we talk about healthcare in the United States. When I was working in the Bush administration, right out of school, I remember conversations where we would look at comparisons of the United States and other countries in the healthcare system. But the reality is most of the benefits that are accruing to the world in the developing countries, the lower costs, are all really born on the back of the United States, right? All the drug innovations that are happening are because you can charge what you can charge in the United States. And so then, sure, if it costs me $5 to produce an actual physical drug and England says we'll pay you 10, then Merck's willing to do it. But if they were no longer able to make money in the United States, there becomes a much bigger question. And I think
that's literally, as you and I are recording this, we're waiting for the National Institutes for Standards and Technology to issue their guidance on the Bayh-Dole marching rule. We spent a lot of time in this show talking about, which is going to completely upend the intellectual property benefits that researchers have in the United States. Let me ask you this, just sort of talking about some of the other issues, telehealth and telemedicine, the work you guys are doing at the state level. Talk about this, the ability to sort of practice medicine across state lines and how important that is.
Yeah. Well, so one of my colleagues, Josh Archambault, has done a ton of work. He puts out an annual report kind of ranking states on where they sit on their telehealth policies. And we believe at Cicero that doctors who, and this is totally separate from the internationally licensed doctors who we think shouldn't have to repeat residency to be able to practice here, but doctors who are, like your wife, licensed in one state should be absolutely able to get on the phone with a patient in another state and get on a video chat with a patient in another state and provide them a consultation, to provide them with a prescription. All of those things that the doctor is able to do, if she or he was able to do those things via the phone in their own state, we think that they should be able to do it anywhere in the United States. And the example that I used on your radio show was, I'm in North Carolina right now, but I live in Virginia. And if I called my doctor today from North Carolina and said, hey, I've got this thing going on and it's something that he's treated before, my doctor legally shouldn't actually do anything for me. Now, he would, because he knows I'm not going to report him to the Virginia Medical Association or to the North Carolina Medical Association. But the reality, legally speaking, is that he would be practicing in North Carolina without a North Carolina license, and that's legally a problem. Now, lawyers create all sorts of problems. I'll be the first to admit it. But this is one of those problems that lawyers and doctors have almost colluded to create that doesn't make any sense in the 21st century. That might have made sense back when there were such unique characteristics of the different parts of the country. But the human body doesn't change when it walks across the state line. And we think that you should be able to treat those patients across state lines.
I'm just thinking about this idea of, if it took me, once they screwed up with my initial Achilles diagnosis, it was going to take me a month and a half to get an MRI of my leg. And I know I wound up being able to sort of, talk to some folks and get in a little earlier. But the idea that, there should be somebody should have come up with a situation, right? Because it's, of course, not just getting my leg scanned, but it's getting a radiologist to read it. And there's no reason why we can't have somebody, in New York or California or wherever, who can go and just create a business where they're reading radiology charts, much, much faster, turn around and get the results, maybe not the same day, but maybe, within a day. So you don't have to wait another week. It took another week for me to get in. Before I let you go, because you've had this varied career, Jonathan, And you were, before you went into the Trump administration, you were at HUD. You then went over to labor. How did you get interested in these healthcare issues? Again, as I said, I'm the regulatory guy, but this is fascinating to me. How did you get interested in this?
Yeah. So when I was in college, I went to Washington University in St. Louis, and a lot of my classmates were on their way to medical school. And so it was always interesting to me, kind of the pathway that doctors face. My undergraduate thesis was on medical malpractice reform.
Oh, wow.
And kind of looking at whether or not patient access to healthcare was improved when states implemented malpractice reform. And so got to do some really interesting work then, got to meet some interesting people as part of that process. And then was blessed to get an opportunity to go work in the Bush administration at the Council of Economic Advisors, working on healthcare policy, learning from some of the smartest people in the country on healthcare, working on health savings accounts, working on trying to change the tax treatment of health insurance, all of those things, and really kind of got an opportunity to really get a detailed education. In some ways, they joked around that I had a master's degree in economics and public policy from those couple years that I got to spend before I went to law school. And so had done that healthcare work and had always been able to be around a little bit of it in private law practice. I was doing product liability and toxic environmental litigation. And so I was interacting with doctors and folks in the healthcare space as part of those projects as well. And so then when I had the opportunity to go to the Labor Department, I didn't get to go to HUD, but I did go to the Labor Department. And when I had the opportunity to go there, the Labor Department kind of covers a lot of things that you wouldn't assume the Labor Department would cover. Your listeners, most of your listeners are, folks who know the policy space, but for those who don't, the Labor Department has almost no regulatory authority over unions. And so you kind of would assume the Labor Department, that's unions, but that's mostly done by the National Labor Relations Board.
The NLRB.
Mostly what the Labor Department deals with is kind of work policy, workforce policy, kind of employment policy. So the wage and hour division, minimum wage, hours recording, all of those sorts of things. And then it also has EBSA, which is the Employee Benefits Security Administration. And EBSA is partially in charge of pensions, and they deal with a lot of healthcare regulation along with the Treasury Department and Health and Human Services. So the price transparency regulations that came out that required hospitals to publish their prices, that was all done in part by the Department of Labor's regulation. So got to do some healthcare work there. And then when I came to Cicero, kind of got to combine workforce and healthcare and coming together with this international physician policy. And also have gotten to do a lot of work on workforce regulatory reform, which was obviously a really important piece of the work we were doing at the Labor Department.
All good stuff. How do folks find out more about the Cicero Institute and the good work you guys are doing?
Absolutely. We would love to have folks talk to their state legislators, rework with legislators in about 25 states around the country. Our website is ciceroinstitute.org. Happy to chat with folks, more detail about international physician policy, about regulatory reform, about workforce policy, about our public safety work, anything that is of interest to your viewers and listeners, we would be happy to partner with them on.
There you go. Well, listen, Jonathan, thank you so very much for joining us today.
Andrew, thanks so much for having me. It was good to be here.
So this has been yet another episode of the Lunch Hour with Federal Newswire. My guest has been Jonathan Wolfson. He's the Chief Legal Officer and Policy Director at the Cicero Institute, a think tank based out of Austin, Texas. If you like what you've heard today, please leave a review, leave us a like, subscribe on the various platforms that are out there. Spread the word about how much you enjoy this by word of mouth. I am your host, Andrew Langer. Enjoy the rest of your lunch.
This has been the Federal Newswire Lunch Hour Podcast, hosted by Andrew Langer. Check out the Federal Newswire's family of websites, as well as their social media stream.